Hey y'all, welcome back to my channel. I'm Muriel. This is Nurse Muriel. As always, welcome to my new subscribers. We are at 769. We are 231 away from our 1,000. My oldest but goodies, y'all already know. Welcome to the channel. This video is another video request, and let me just say thank y'all for all the video requests. Y'all are giving me topics on topics that I would have never thought about making a video on. You know, when you've been doing this so long, the stuff is like not new to me, so it doesn't seem like it's something that I should talk about. But I have to remember there are nursing students who watch my video. There are nurses who have never worked in long-term care who watch my video, and there are nurses who are in long-term care who probably know this and they can add on to what I'm telling you who watch my video. So no topic is irrelevant. So I appreciate you guys for all the video suggestions. This video is about death in long-term care facilities. People come into long-term care for different reasons. Some people come to long-term care facilities for rehab, in order to strengthen, to get better, in order to go home. Then there are those who come to long-term care with the hopes of getting better, strengthening, improving in their ADLs, but they don't have the ability to function at a level where they can live alone. These residents in particular end up becoming long-term care residents. Becoming a long-term care resident doesn't mean that you're preparing for death. There are residents in long-term care facilities who have been there 10, 15 years. They're not coming in there preparing to die. Long-term care is not a death sentence. I just want to say that right offhand. However, when you're living somewhere, and this is where you plan to live the rest of your life, of course, the end of life is death. There are certain protocols that have to be followed when there is a death in a long-term care facility. And I'm going to speak specifically for South Carolina because this is where I reside. We have some patients who are in long-term care facilities who have terminal illnesses. And certain terminal illnesses, you qualify to become a hospice patient. Hospice isn't a specialty, I don't believe. It's more like an agency. And when you become a hospice patient, your family and the resident basically agree that this condition I have is terminal and it could lead to death. More so lead to death more sooner than later. Not saying you're going to die tomorrow, not saying you're going to die in a month. I have had hospice patients who have been on hospice and they died a year, 2 years later. Normally with hospice patients, there's a hospice nurse who comes in and who checks on the patient. Sometimes they come daily depending on the facility. Like where I am, there's in-house hospice. Sometimes they come in weekly, but they come and they check in on the patient. A lot of times hospice provides the medical equipment for the patient, like air mattresses, different types of oxygen concentrators, different things they supply. They manage the medical care because normally the hospice doctor will make the orders for the hospice patient. So say we have a patient who they don't feel like this medication is no longer necessary for the patient. They'll probably discontinue a bunch of medication. They'll more than likely put them on more once their health deteriorates and death is looking more imminent. They may just put them on a bunch of comfort medications like Ativan, morphine, atropine to handle the discomforts when you're actively transitioning. The nurse in the facility is there. She sees the hospice patient may be taking a turn for the worse. There are certain signs you see in a resident when you know a resident is about to transition. The nurse of the facility will call the hospice nurse, will let them know how the patient is faring. Normally, the hospice nurse will come in, she will do her assessment, and she will reach out to the family. She'll reach out to the hospice doctor. She'll update the family on the patient's conditions, things like that. She may ask you to administer certain medications to the patient because she cannot administer the medications, but she can ask you to administer certain medications if she feels like the patient needs it at that time. Usually with a death with a hospice patient, the hospice nurse takes over everything. You do have contact with the family members once they start coming in. I allow the family to spend time with the patient. I don't do a bunch of in and out. I'll pop in, see if they need anything. But I let them spend time. I allow them that time with their family member. Sometimes the family member isn't there when a hospice patient pass away. You, as the registered nurse, you can pronounce when a patient has expired. I have pronounced patients that have expired in long-term care when there are no heart tones, no audible heart tones. Listen with the stethoscope. When there are no visual respirations, when you see no rise and fall of the chest, no respirations, when there is no radial pulse, you don't feel a radial pulse, you don't feel a carotid pulse, when there is no signs of life in the patient, and you verified it by checking those things, you can pronounce that the patient has expired. You can call the hospice nurse. You then call the hospice nurse and you notify her. 9 times out of 10, the hospice nurse makes all the notifications to the family that a patient has expired. They handle all that. You do your documentation as the registered nurse that you did the assessment that was needed. You do that documentation, you notify the hospice nurse. Normally they take it from there. They'll even call the funeral home. They'll make all those arrangements. There is a paper that needs to be filled out when a patient expires. I have never filled that paper out. I do need to learn how to do that. I don't know if sometimes the funeral home brings it. I believe sometimes the funeral home brings it. I think it's just like a certificate of death. I'm not exactly sure about the paperwork part, y'all. I'm not gonna lie to y'all because I've never had to actually fill out the paperwork, because the majority of times that a patient has expired on me in long-term care, they have been a hospice patient. Now, there have been times when a patient has expired who has been full colds, y'all. Let me tell you, I had a patient once who was a patient who used to decannulate herself all the time. Decannulation is when they pull the trach tube out of. She used to decannulate herself. She used to get congested a lot. For one, she used to get a lot of mucus plugs in her trach. You had to constantly suction her, which for that alone, I feel like she should not have been in long-term care, because that level of acuity is too high for a nurse who has 20 other patients, because there's no way you can be in there constantly suctioning a person who gets like mucus plugs that often. But she also used to decannulate herself often. And when you decannulate yourself, there is no way for you to get oxygen. This patient decannulated herself. This patient, when last seen, not even 45 minutes before, this patient was a full cold. The tech doing her rounds saw that the patient had no respiration. She notified me. I was the nurse. We immediately got in there doing CPR on the patient. We already know when a patient has those. Okay, let me just say this: when you have a patient like that who I'm gonna say does things that are self-harming, you're gonna find out right off the rip if this person is a full cold, because you already know. You're gonna find, as a nurse, you're gonna try to find out that if you're gonna know automatically if this patient is a full cold or not. That's gonna be the first thing you look for, because as a nurse in a long-term care facility, you're gonna want to know if your patient is a DNR. You're going to want to know those things. This patient happened to be a full cold. Yeah, we had to get in there. We had to start doing CPR on this resident. Had to have someone, call EMS and all that. We're doing CPR. We're doing CPR. The patient was last seen probably like 45 minutes before. And I don't know when this patient decannulated herself, but she did not hit the alarm to call for any assistance. We observed her, a CNA observed her with no respirations while she was doing a round because it was at the change of shift. EMS came, they did their thing. EMS is going to do their things for so many rounds of epi, for so many. They put the thumper on her. The thing that does the compressions. They're going to do it for so long, and then they're going to call time of death. And you, as a nurse, then you have the responsibility. They have in South Carolina, you have to notify the coroner when a patient dies in long-term care facility. Sometimes the coroner will come out. Sometimes the coroner will just want the information given to them over the phone. This particular time, the coroner came out. I don't know why the coroner decided to come out on that one, because I have had to call the coroner before, where the coroner never showed up. They just got the information over the phone, and that was that. But the coroner did come in for that one. I had to notify the family member that the patient expired. I had to find out from the family member what funeral home they would be using. Then you clean the patient up. You take out any tubes that the patient may have. And I remove all tubings. If the patient had a peg tube, I'll remove the peg tube. I'll remove the Foley. If they have any IV sites, I remove the IV sites. You bathe the patient, you get them ready for transport. I still do the old school when you roll up. Normally the techs will do it. They'll roll up a towel and they'll put it under the chin so that the patient's mouth is closed, because when rigor mortis sets in, you don't want their mouth to be open. You lower their eyes. If possible, you lower their eyelids so their eyes are closed, and you have them bathed and ready for transport for when the funeral home gets there. So one thing I can say about me is I have a hard time consoling people. Consoling people is not my strong suit. I have always, and this may sound strange, y'all, I have always had a problem with touching, hugging. Like I just don't like to hug, and I just don't like to do that. And so I show compassion. I don't like to touch. I don't like to hug. I don't like to do those things. What I do is cry. I am a crier. And it is so difficult for me to console family members when I myself cry a lot when it comes to seeing other people's emotions. So if the family is there and they're crying, I tend to end up crying as well. And so you shouldn't do that as a nurse. So that's why I have a hard time with consoling the family. Some people are so much better at it than I. A lot of people are so much better at it than I am. I do console them to the best of my ability. I am not the best at it like some people are. I do try to console the families to the best of my ability. I have on occasions had to, hugged it out with the family members and things of that nature, which that is so uncomfortable to me. I hate to say it, but it's so uncomfortable. I don't even like shaking hands. Like, even before C19, I never liked shaking people's hands. And hugging is just a big, it's hard for me, y'all. It's hard for, especially people you don't know like that. It's really hard for me to be hugging people. So I like that. And I know that's I like that when it comes to consoling families. That's kind of what you do when there's a death in the facility. Whether it's their DNR, say someone has something going on in their DNR, you're not going to initiate CPR. But what you are going to do is still reach out to the doctor and say, hey, say a person is a DNR, but their respiration, their oxygen saturation is like 79%. You're not going to just say, oh, well, they're a DNR. So no, you're still going to reach out to the doctor. You're still going to put that patient on some oxygen. Your DNR does not mean, okay, well, we're just going to let them die regardless of, whatever happens in their body happens. We're just going to let them expire. No, that's not what DNR is for. So even if a patient is a DNR and certain things are occurring with them medically, you're still going to tend to what's going on with that patient. You're still going to call the doctor about acute things that's going on. You're still going to send them to the hospital if the doctor and the family agree to it, that they need to be sent. DNRs do get sent to the hospital, y'all. DNRs get sent to the hospital. If a patient is a DNR in your facility and something happens where, say, like they're declining, you still are going to try to treat them in their decline. You're just not going to provide CPR, but you will try to treat the symptoms, the signs and the symptoms that are occurring in that moment. If a patient is a full cold, you're going to try to get that patient out of the facility before it gets to the point of CPR. You're not always successful at doing that. Like I said earlier in this video, where the patient decannulated herself, she was a full cold, CPR was initiated. I have done CPR in long-term care quite a few times, y'all. It's very exhausting. I try to get the patient out of there to the hospital before we get to that point. I try my best, but sometimes things just happen. Like, your patient can be fine 1 minute and then 5 minutes later you're coding them. It can happen like that in long-term care. It happens. No audible apical pulse, no audible heart tones, no palpable pulse. I normally put no palpable radial or carotid pulse, no respirations, no rise and fall of chest. All the signs that a patient has expired, I document those things. The goal is to not have to have a death in the facility on you, but it does happen. And if it happens, my heart goes out to you. Y'all, I hope y'all understand this video. I'm all over the place. I might need to do another one. I'm going to put this one out. If y'all got any questions, though, I'm sorry. I have such a hard time getting my thoughts together. It's like I know the process, but actually talking it out is kind of difficult for me. But if y'all got any questions, leave them down below. I'm Muriel. I will talk to you guys later.